All right, let's get started. So welcome to Noon Conference, everybody. Like Dr. Connor said, this is our educational conference for today. It'll be a cold case that is presented by Mike. And so what I'll do is I'll have our presenter and discussants introduce themselves in the order in which their picture appears, and then we'll get started. Mike, take it away.
Cool. Hey, yeah, I'm Mike. I'm an R2. I came from Georgetown University on the East Coast, and yeah, love in Colorado.
I'm Megan. I'm an intern at R1. I came from the University of Washington in Seattle, and yeah, I've been loving skiing in Colorado.
Hey guys, I'm Guille. I'm originally from Texas. I graduated from Texas Tech University in El Paso, and I'm a second year. And much like Megan, looking forward to the ski season. I don't know if Sophie's here or not.
I think I saw her name pop up. Hey, Sophie.
Hey, can you guys hear me?
Yes.
Okay, awesome. Hi, I'm Sophie. I'm a third-year resident. I'm originally from Charleston, South Carolina. I also did med school in DC at GW, and I'm in the primary care track, and so feel free to reach out to me if you have any questions about that, and I'm going into geriatrics next year.
Congratulations, Sophie, on matching to University of Michigan for geriatrics. And many of you met me last night. I am Sneha, one of the inpatient chief residents here at University of Colorado, currently located at the VA inpatient position. So today, we want to welcome all of our applicants. We're really thrilled that you all are here interviewing with us and are excited that we're interviewing folks from all around the country. So welcome. Please take this opportunity to sit back, relax, and enjoy the conference. Think of it as a time after your interviews where you can wind down. If you're really interested in participating or have any comments or questions, please put them in the chat, but we'll be happy to run the case with our presenter and our discussants. We also have some fantastic attendings that are here. Dr. Connors, who's a pulmonologist, Dr. Kearns from Denver Health, as well as Dr. Albert, who are all really helpful during the case for when we need a more experienced opinion. So for our teaching,
Dr. Chan is here today as well.
Oh,
we should
fantastic!
Mention.
Great.
Welcome him as well. Also,
yeah,
a great
welcome,
experience.
Dr. Chan. Yeah. So for our teaching structure for the applicants, before COVID, all of our conferences were in person. Lunch was provided across our sites, and we gathered, we had fun, we socialized and learned during the noon hour. In the COVID era, what we've done is transition to daily virtual conferences, much like what we're doing now. And so this isn't out of the ordinary. When we can, we still try and do in-person conferences safely with masking, which are currently on hold, but this is something we try to do even during COVID if we feel that it's safe to do so for our residents. And then finally, we've been uploading these conferences to our YouTube channel so that people who aren't able to log on live can watch them later. And so feel free to check it out. It's under CUIM Residency YouTube channel. And then since we're about halfway through the years, the interns are getting seasoned, the third years have matched into exciting fellowships. We wanted to see if you guys could stump the chiefs. And so for our residents, we have an offer for y'all to come up with a case that you think could stump us. And we'll do a conference in this style where the chiefs are the discussants and you can present us a case that you think we may not be able to crack. But we're really excited for something like this. And so think of a case, keep on the lookout, and we'll do this conference whenever you all are able. So for having said that, let's get started. I'm going to let Danny share his screen and for Mike to take away the case.
Awesome. Thank you. I just want to give a big shout out to Sneha too for helping organize this presentation today. So thank you. So this case actually starts my February month of intern year at the VA. And it starts with a 67-year-old man. He has a history of hypertension, hyperlipidemia, some coronary artery disease that he got stented in 2019. And he's coming to us with sinus congestion, rhinorrhea, and a cough that's been going on for about 5 months. And so you take a little bit more history and you find out that he's gotten multiple courses of antibiotics from his PCP. Looks like he's been treated with penicillin, ampicillin, even a fluoroquinolone, but despite that, his symptoms continue to persist. And just prior to coming to you, he's actually referred to ENT, who did a CT sinus that showed pansinusitis with a septal deviation. And then he comes to you 1 week after that with ongoing complaints of congestion. Maybe I'll leave it there.
Let's see what our discussants are thinking when they hear a history like this, and thinking about sort of what illness scripts are starting to develop given the patient's age, the course of the illness so far, what you're hearing.
Well, okay, no, please.
Yeah, so I guess first things, just kind of thinking, running through the book of differentials, what could be going on, right? You know, other than just plain old chronic rhinosinusitis, why is he having that? Is there something obstructing his sinuses? So the first thing I would be thinking in a 67-year-old, any sort of malignancy, head and neck cancer. And I would ask a little bit more about his social history, social habits. So is he a smoker? Is he a drinker? Has he had any history of cancers?
Yeah, Sneha, is it good to go ahead and share that now?
Yeah, please go ahead.
Yeah, cool. So on his social history, it turns out he's a never smoker. He used to drink pretty heavily, but he quit 10 years ago. No recreational drug use. He's not sexually active. And for as far as like exposure work, he works as an apartment security and kind of like a building manager. And he's from Wyoming, coming down to our VA. Kind of with that, he also has not traveled outside the US ever, and he hasn't been traveling recently outside of Wyoming.
Yeah, I think going along that, I was worried about like why a patient might be immunosuppressed. I feel like with that social history, it kind of makes HIV seem less likely, but not ever off the table. And obviously, if you had a malignancy and was like neutropenic, that would also potentially be a problem.
And Megan, I don't know if Guy mentioned this, but tell me why you mentioned the word, or why you think the patient may be immunosuppressed. What about his history points you toward that?
I mean, this could all fit along. I think just anytime someone's having recurrent infections, it's usually not random, especially if they've been like adequately treated with the appropriate antibiotics. So like source control, appropriate antibiotics, and right bug, I guess. And then also his review of systems is just the classic concerning things for malignancy or immunosuppression, like weight loss, fatigue, hemoptysis, and night sweats.
Yeah, and then I would also want to know like more common workup for chronic cough. So like, I mean, GERD symptoms. I know this is noon conference, so it's not going to be GERD, but definitely if I was in the office, I would worry about postnasal drip and just sort of also why they think it's recurrent like infection of the sinuses, because that's not necessarily what I think of when you say chronic cough and nasal congestion, and then also just quantifying his constitutional symptoms. And I'm also just noticing now he's having hemoptysis, so that's also concerning.
Yeah, thank you, Sophia. I think you pointed out that even when we see patients like this, to make sure that we're thinking of the most common things along with our most deadly things, which I think you guys are doing appropriately. And I would just add that the three most common causes of chronic cough in the outpatient setting are two of which you mentioned, postnasal drip and GERD. And the third is undiagnosed asthma in an adult. And so thinking about that as well. Okay, I'm seeing some things here in the chat. So let's see. Somebody commented that with that ROS, they're concerned about TB, a fungal infection. And so we're thinking more of the subacute to chronic infections as well. Dr. Albert says postnasal drip can cause cough, but any conditions that would affect the sinuses and the lung. Infection
I guess one of the
mimickers.
clarifying.
Yeah, go ahead, Mike.
I was going to say one of the clarifying things I should say is, you know, when he's coming to us, he's saying he's coughing up blood. So it should probably be like blood per aura, because we don't still know at this point where exactly it's coming from.
Mhm. And then we're seeing some things about infection mimickers, things that cause chronic inflammation, like some of our rheumatologic conditions. Okay, Mike, somebody's asking if the patient has any autoimmune history. So why don't we actually just tell our folks the past medical history and the rest of the histories?
Yeah, so so his past medical history is rather unimpressive. So he presented in 2019 with acute chest pain, was found to have some pretty bad CAD, and so he ended up getting 4 stents. And with that, he has a history of high blood pressure and hyperlipidemia. Yeah, but otherwise, on a pretty thorough review, all that was significant was he had a provoked DVT back in 1990 after he had a knee arthroscopy. And then his family history was not significant for autoimmune conditions. He had a sister with breast cancer, and he really couldn't recall if his parents had any medical conditions when we were interviewing him.
Any like recurrent infections as a kid or ever?
Yeah, no, he denied like a relatively normal childhood as far as infections, and even into adulthood, he's never really dealt with recurrent infections. I saw somebody asked about birds in the comment, and it feels like we haven't gone a noon conference without getting a good history on birds, and so he does not have any birds in his home.
So I'm a proponent for continuing to refine the differential as more and more information comes up. And so do you guys want to do that for us and just think about, you know, how has your differential changed with this information? And if you're thinking of any other diagnoses.
I'll say it hasn't really changed much for me, but just with everyone's comments and some of the teaching points that we've touched on, organizing ourselves, right? So we've talked about malignancy, we've talked about infectious processes, rare things, any vasculitides. Let's see. And then in this questionable history, well, not questionable, we know he's bleeding, but we don't know if it's coming from his GI tract or his lungs. Given that he has more of a like chronic sinusitis sort of picture, I would say it's probably coming from his lungs. So some sort of pulmonary disease. And then I think I saw Dr. Albert say which vasculitis. I'd probably say I always forget. It's not Wegener's anymore. It's granulomatosis with polyangiitis, or good pastures, I think, is another one that can cause sinusitis.
You have microscopic polyangiitis, you have kidney dysfunction.
Yeah, he doesn't have any CKD, right, or anything like that. Any renal disease that we know of?
No.
Wow.
Yeah, can you quantify a little bit more? Tell us more about the hemoptysis, like how much it is, how much it's happening.
Yeah, so it wasn't some of his initial symptoms when he first developed these sinus symptoms. It really started to develop in kind of the weeks preceding. So, you know, his course was over about 5 months. So a few weeks before we saw him, noticed onset of some very insidious shortness of breath, particularly with exertion, and then some scant hemoptysis at times when he was coughing. The cough was much more chronic kind of throughout the course. And it seemed at times plus or minus productive of like some green sputum. The blood would be kind of laced in the sputum when he did have it, but very scant.
One thing to now with that additional history, I would say with his history of 4 stents, which is on the lower end for our vets, I would say, one thing we don't want to miss is heart failure. Heart failure can also cause some hemoptysis, especially the shortness of breath. Something to think about. I don't know how to explain it in conjunction with his congestion, but cardiac causes are one thing we don't want to miss.
Yeah.
Sorry, going back down to his social history, any occupational exposures that are concerning? Like, what was his tour like? Secondhand smoke? Any other?
So I'm actually not recalling offhand where he did his tour as far as his military history, but it was not relevant to his presentation. The only other exposure history that you can maybe think about is, before he became a building manager, he worked for many years as an auto mechanic, and so he's around car exhaust a lot, but otherwise, no other significant exposures that I could think of. I see Porva's asking in the comments if there was any medication or supplements used recently. And in fact, he came to us not quite a year out from his stents and was lost to follow-up and wasn't taking his Prasugrel, his statin, his aspirin. So he wasn't taking any medications.
And then Mike, just
one last question for,
yeah.
Oh, sorry, I just want to ask Mike, we haven't talked about, does he have kids?
He does not. So he's single. He does not have any children.
Okay. I only ask only because Dr. Chan and Dr. Albert are smarter than I am, and they're going to think of even better rare birds in a second here. But I think ciliary dyskinesias need to be on our list of things. So when you think about sinusitis, hemoptysis with bronchiectasis, Cartageners or something, and someone who doesn't have any kids, maybe because he's single, maybe because he can't.
Mm.
Mm. Thank you, Dr. Connors, and thank you for telling us why you asked your question. So, what? Don't know if Danny left. Maybe having
Still seeing here.
difficulties. Mike, just to round out the exposure history, somebody commented that they're concerned about TB in this patient that's having weight loss, hemoptysis, chronic cough. And so would you mind just telling us whether he has any risk factors for TB?
Yeah, and that was something we were certainly concerned about when he shared those review system symptoms. And so he has never traveled outside of the continental US, with exception probably for his tour, but it was decades ago. And then otherwise has lived in Wyoming his whole life. He's never been incarcerated. Yeah, I think that was kind of the main things.
Yeah, being from an endemic country, traveling, incarceration, and then homelessness are the common risk factors for TB, at which we ask. And then healthcare providers, of course, that routinely interact with patients who have TB. All right.
That's right.
Unless our discussants have any other questions, we can provide you with the vitals and exam. Let's do it.
Awesome. So, so in the ED, which is where we saw him, he was afebrile. Blood pressure was 128/72. His heart rate was 73, and he was sitting 94% on room air. As far as his exam, so he overall was pretty well appearing, wasn't in acute distress. Listening to his lungs, he actually sounded clear throughout. Couldn't hear any rhonchi or wheezing. Normal cardiac sounds, regular rhythm, and then abdomen benign. Skin check was normal. And then I think probably the most important exam that you guys are looking for up front might be his HENT exam, which I think we have here.
That's abnormal.
Yeah, what are you guys seeing?
His nose has 2 tips.
Yes. Okay. Danny can take back over here, but let's see what is there in the chat. saddle nose deformity. Great. So I'll let you all keep talking. Megan says syphilis. Another Megan.
I agree with Megan. I don't have a great differential for a saddle nose off the top of my head, but certainly raises a concern for infection. Did you look inside his nose?
Yeah, so looking inside his nose, he had, so he, just a week before, he had this bilateral maxillary turbinate reduction. So he had some crusted blood, and kind of around that you could see some erythema of the surrounding tissue, but it was rather congested with the kind of scabbing that was there. And the deformity itself was like, it was non-tender to palpation. He was certainly concerned about what was going on, and he noticed the progression of it about a week as well before he came in to see us.
I mean, that seems awfully fast. And I feel like he's not currently sexually active. So if he had syphilis, that would have been there for a while. So I think, I don't know, that makes me a little more worried about like HIV and some kind of immunosuppression that would be contributing. PA?
Sorry, say that again, Megan. I was reading the chat.
Oh, I was just saying that it seems awfully fast for the saddle nose to develop in like a week, and he says he's not sexually active. So if he had syphilis, like some people were suggesting, then that would have been there for a while, and that seems odd.
I also thought saddle nose deformity is like at birth. It's like congenital syphilis, but I may be wrong.
I think that's true.
Well, I guess the other thing I was going to suggest too is his joints. Any inflammation, any like digit deformities or anything like that?
Yeah, great question. So his MSK exam was pretty unremarkable. He didn't have any evidence of synovitis or kind of joint deformation, no rashes on his skin. And then and was normal as well. No evidence of like localized paresthesias that he was describing, and certainly no like deficits in his neuro exam.
I'm also like trying to think if this could be like bone destruction of some kind and why that would be happening so quickly. Yeah, and it's trying to fit it in with the cough too.
Okay, so in the chat, we have a few folks, including a couple of our expert consultants, saying that saddle nose deformity is classic for GPA. A few other people have also mentioned GPA here, and then ANCA vasculitis. And so Guy already mentioned vasculitis as one of the rare causes of this syndrome in his differential. And so focusing on all the differentials that we've gathered thus far, what labs would you want to order for this patient?
Start with a CBC.
What are you say?
CBC.
I'm going right in. There's like the anti-myeloperoxidase antibody, which can never remember which one that goes to. Then like the anti-GBM, those might be the same. And then ANCA, PNC, probably ESR and CRP would get sent. BMP, look at his creatinine.
And if you want to even be a little more specific about it, because I agree, all those are absolutely going to get sent for sure. What do you want up front in this person? Like before we go down a pulmonary renal pathway, what do you want to start? Just a couple of basics you want to start with. And it doesn't mean for Megan, it could be for anybody.
Probably a rapid HIV, just because of the recurring infections. It's easy to do.
So it was pre-COVID, so can't order COVID.
Also, some infectious studies as well, probably in RPR, since we were considering syphilis.
Yeah, I think for the purpose of teaching, as a Dr. Farnes again, we can kind of think about them in buckets. Like we usually send baseline CBC, probably a CMP in this person, usually a UA, so we can kind of get a baseline of what their overall organ function is like, and then do like infectious workup. So that'd be like the RPR, the HIV, probably end up getting a Hep C, and then you could do like the autoimmune, rheumatologic stuff that I was kind of starting with.
Yeah, that's good. I appreciate that. I like the buckets if nothing else. And I see a couple people in the chat here, getting at you're going to get, everybody gets a CBC and a 7. So that's sort of like the consonants and wheel of fortune. That's a given. In this one, I like the UA off the bat. If there's no red cells, you're gonna have a hard time making a case for a pulmonary renal syndrome. There's always post-immune manifestations of everything. So it's possible. But I think you get a UA with some blood, you at least can start going down those pathways that you're all talking about.
Great. Well, let's see what labs we obtained. I'll let you all take a look at those for a little bit and then tell us what you think the diagnosis is.
Appreciate Jamie's highlighting.
I'll be honest with you. I don't know what PR3 serine is, or maybe it's under the name of something else. But with the positive C ANCA, well, let's just start from the top. So he's got a white count. He's anemic. He's thrombocytopenic. So if nothing else, there's some sort of inflammatory process going on, and we're confirming his anemia. His bleeding with his anemia. I think, did he have an MCV? I don't know if it's normocytic or microcytic. But.
I can tell you. Let me see. I don't recall offhand. I did not write it down, so it must have been normal.
I mean, it's probably related to the hemoptysis. If anything else.
Can sometimes be bone marrow suppression due to chronic inflammation as well, right? We know that our body does that. And you can confirm that sometimes by mildly elevated ferritin levels. Keep going.
Yeah, I mean, and then his BMP looks pretty unremarkable. His LFTs, I mean, albumin of 2.9, total protein of 7.4. So Danny, having highlighted those, is probably wanting to indicate that there might be a protein gap. And there is actually 7.4 minus 2.9. I always suck at mental math. What is it, 4.4, 4.5? And then PR3 and C ANCA. Yeah, so C ANCA, I mean, more likely to be representing some sort of vasculitis. I think granulomatosis with polyangiitis.
Great. I will say a caveat with that protein gap there, Guy, would be that be wary of protein gaps in patients that have hypoalbuminemia, which is a marker of inflammation, right? And so sometimes these patients will have these increased protein gaps, and so think about, do you truly need to go down that route, which seems like we did here, at least obtained an SPAP.
Right, that would make me think more of like a multiple myeloma picture or something like that, which I don't necessarily think is going on in him.
All right, so Megan, go ahead.
Oh, I was just saying his SPAP looked okay.
All right, so what we'll do here is we will show you his lung imaging. And this image scans from legs up, so it is backwards, and so be mindful of that, but shouldn't be a problem for our pulmonologist. And for you the right way. Oops, sorry. And I'll scan back and forth here. Dr. Connors or Dr. Albert, you want to tell us what you're seeing here?
You want to go first there, Rick?
It's not very subtle.
What is
There's a big, there's a big cavitary lesion in the right lung, possibly with some growth from the wall, but and there's also right lower lobe infiltrate. It could be compressive atelectasis there, but it looks more like an infiltrate to me. I can't tell if there's mediastinal adenopathy, but there could be. And that cavitating nodule would be very consistent with GPA.
Mm-hmm. All right, Danny.
Yeah, I was gonna say, I totally agree. The only thing I'll add is it's interesting if you can go back to that where that nodule is, Sneha. You'll see the fissure exists right above it. So you can sort of scan here. Nothing in life is perfect, but cancer is one of those things that does not obey the fissures. It just grows through things, whereas infection and inflammation tend to stay within their zones. So, you might see this and think, how do I know that's not just a big cancer in there? And if we didn't have any other information, you wouldn't right away. But that makes me feel a little more reassured and pushes me toward GPA as well.
Got it. Wonderful.
It's probably worth mentioning that whenever you have a cavitary lesion due to anything, there is the possibility of colonization with aspergillus, and that raggedy wall of the cavity would be consistent with an aspergilloma on top of it, but that's not the primary condition here. That would be a secondary complication.
Well, so, the diagnosis, I think many of you made quite early on in the case, especially with the saddle nose deformity, the labs, and now this imaging also supports it. And so what I'll do is I'll have Mike go through the rest of the imaging and the further studies which were done with this patient, and then we'll do some formal teaching on the case.
Awesome. Yeah. So that CT, as we just saw, had a 5.2 centimeter cavitary lung lesion. We did have mediastinal lymphadenopathy. And so this was actually an image that was done in the ED when he was presenting with shortness of breath. And so it was actually a PE protocol study. And so at the time, though we were certainly concerned about GPA with the saddle nose deformity, we ended up wanted to be assured that we could rule him out for tuberculosis with that cavitary lesion. And so he was ruled out with AFB smears. And so subsequently underwent a bronchoscopy that just showed diffuse purulence throughout his large airways. And we ended up getting transbronchial biopsies of that lesion in the right lower lobe. And it showed a mixed acute on chronic inflammation with some rare giant cells. It was negative for any infectious organisms that could be seen on gram stain or culture. And then it was also sent for cytology, which was negative. And then we were able to get outside records from the ENT that he went to before he was admitted, where he had the bilateral maxillary sinus resection. And we were able to get the path report, and it showed that there was acute on chronic inflammation with necrosis within the tissue as well. So after that, we consulted room, but solidified the diagnosis of GPA. And his course was actually complicated. He was discharged home, but actually came back a few weeks later with, or at 2 weeks later with pleuritic chest pain. And he actually developed a abscess, fluid-filled cavity within that prior cavitary lung lesion. He was septic. And so he actually got readmitted to be treated with antibiotics, from which he did recover from. He was eventually cleared and started on rituximab. And I just checked on to see how he was doing. It seems like he's doing pretty well on rituximab right now.
Fantastic. Okay, so the case conclusion here, as Mike mentioned, we have our final diagnosis of granulomatosis with polyangiitis, or GPA. This patient predominantly has sinonasal disease with pulmonary involvement. He's following rheumatology, is currently on rituximab and prednisone, and he has had a couple of superimposed pulmonary infections and some hearing loss. So only 10 to 20% of patients have renal involvement at diagnosis, but about 80% will go on to develop renal disease. And so monitoring these patients closely is very important. Obtaining both urine microalbumin levels to look for proteinuria, and then following creatinine levels to look at GFR is important. And then as somebody mentioned in the comments earlier, sinonasal disease is seen in about 90% of GPA cases, and so is very common. And these appear as a conglomerate of chronic sinusitis, otitis media, mastocytitis, and hearing loss. The objectives really for the case today were, which we'll do here in a second, which is to build a schema for cavitary lung lesions, and timing during which these appear is a big clue, to differentiate between various small vessel vasculitides, C versus P versus non-ANCA associated. And then we're going to understand ANCAs just a little bit better and clarify this terminology. Gay mentioned he isn't sure what serine protease is, and so I'll go into that a little bit and we'll talk about what these terms mean. So first,
Never mind it. You recognize them now.
you got it now. Yeah, it's just different words for some of the same things. So we'll go through this this pictorial, this table of cavitary lung lesions. And really the steps are first to make sure that you're not looking at what looks like a cavity but isn't. And so often patients that have emphysematous or cystic disease can look like they have cavities, and to ensure that that's not part of their history and that you're looking at a true cavitary lesion. And then once you are confident that you're looking at a cavitary lesion, it really comes down to this timing. And so patients that have acute to subacute illness less than 12 weeks are generally considered to have acute infections. And these include pneumonia that is necrotizing, lung abscess, septic emboli from endocarditis, other fungal infections, all of which appear more rapidly and are quicker in onset. And then the bucket of chronic infections is larger, or sorry, the bucket of chronic cavitary lesions is larger. And these are ones that have been there for longer than 12 weeks, or that the symptoms or course of their illness has been longer than 12 weeks. And so the buckets are a few. First is to think about chronic infections, TB, which is something that we thought about pretty early on for this patient because of the duration of his symptoms and then the fact that he has a cavitary lesion. TB should be on the top of your differential. Additionally, we want to make sure we're protecting our staff, and so using the appropriate isolation methods if you're considering TB as a diagnosis. And then of course, all of our other microorganisms fit in there. Another thing to think about, which we did in this case as well, is to think about malignancy, primary lung cancers versus metastatic disease. And thanks Dr. Connors for teaching us that usually malignancy will blast through the patient's fissure. And so in this case, we saw that that cavitary lesion was contained with the borders of the fissure. And then the last bucket, as is the case in our patient here, is autoimmunity. And most commonly, it's GPA, and then RA as well can cause cavitary lesions if there is lung involvement. And so for our patient, he ended up having GPA, even though it seemed like some of his history was more consistent with malignancy or chronic infection. But we know his sinonasal disease really put him in that autoimmune category with GPA. If you want to read this paper, which appears in CHEST, there's a QR code, and I'll let y'all take a picture of that here for a few seconds. It's a really great radiographic and diagnostic review of cavitary lung lesions in the journal CHEST. And I found that to be really helpful in thinking about cavitary lung lesions. So next up, we'll talk about small vessel vasculitis. I think you all covered most of them in our differential. And so on the left side here, we have ANCA-associated vasculitis, and then we can also have non-ANCA-associated small vessel vasculitis. Above here, they're still using some of the old terminology as in Wagner's and Churg-Strauss, but I have that clarified to what we call them today. And so ANCA-associated vasculitis really is differentiated by whether there are granulomas present or not. If there aren't granulomas, then it's microscopic polyangiitis or MPA. And then if there are granulomas present, then you have to think about whether the patient has symptoms of asthma, and then whether the patient has peripheral eosinophilia, which would put them in this eosinophilic granulomatosis with polyangiitis or Church-Strauss. If they don't have that, then they go into the granulomatosis with polyangiitis bucket, which is what our patient had. And then to think about these non-ANCA associated vasculitides, we have Hemlock-Schönlein purpura, which is now called IgA vasculitis. And that's if you have IgA dominant immune deposition. And if you don't have that, but have cryoglobulins, then you have cryoglobulinemia. And so Megan earlier mentioned that she'd like to get a Hep C in this patient, which is something to consider. One of the common reasons for patients to have cryoglobulinemia is Hep C. And then other disease-related vasculitides, Dr. Chan mentioned APLA can sometimes cause vasculitis. Inflammatory bowel disease-related vasculitis also falls under this category. And so these entities are small vessel vasculitides. So a little bit about ANCA and this terminology and what we're actually talking about when we throw around terms like C-ANCA, P-ANCA, PR3, MPO. So what are we actually talking about? So first, just to clarify, ANCA in itself is the anti-neutrophil cytoplasmic antibody. And so these are antibodies that attack different parts of a neutrophil. With this attack, the neutrophils become activated to infiltrate our vessels, which is why a patient gets vasculitis. And so this is ANCA-associated vasculitis. The terms P-ANCA and C-ANCA really refer to a pattern and just mention a generic antibody. And so if you have these antibodies floating around in your blood, your ANCA will be positive. Whether you call it a C-ANCA or a P-ANCA is based on the indirect immunofluorescence, which is what I'm showing here, and the way it patterns. And so P-ANCA is perinuclear, and so you can see there's some cytoplasm there that isn't lighting up, and the immunofluorescence is really around the nuclear site. And then C-ANCA is cytoplasmic ANCA, and so most of the cytoplasm lights up, and it's an immunofluorescence pattern. And this is typically thought of as a screening test. It can be positive in patients that may not actually have the diseases associated with these. What we really need to get for these patients are ELISA tests. And so PR3 ANCA or MPO ANCA ELISA. And what is this test? So what they essentially do is it's a bunch of antibodies tagging with each other. And ultimately, if you have a PR3 ANCA complex in the patient's serum, then the enzyme will light up and the ELISA will be positive. And so PR3 and MPO are protein targets or the antigens for the antibodies for the ANCA antibody. And so essentially this ELISA test will look at the ANCA antibody binding to PR3, which is the protein antigen for the antibody, and you get this PR3 ANCA complex, and that's the test that's done by ELISA. It can be quantified, and this is a very specific test. And so if you remember, under our labs, we reported both a C-ANCA titer, which was 1 to 80, which is high, but we also reported a PR3 level, which is essentially this ELISA test, which looks at whether the PR3 ANCA specific complex is positive in the patient, which in our patient was very high. The upper limit of normal here is 3.5, and the patient's ELISA quantification was 73, so really high. So there are some international consensus, not sure what the plural is there, about what to do when you're suspecting ANCA vasculitis. And so the original consensus, and sometimes what we still do, is to actually check the immunofluorescence or the pattern first, right? We think in our mind, does the patient have P or C ANCA? But that's an outdated method. And what the international consensus now recommends is that we actually do the PR3 or the PR3 or the MPO test first. And so this is to summarize to say, if you're going to order only one test for these patients, you should order the PR3 ANCA or the MPO ANCA ELISA and not just the generic C or P ANCA test. Getting an ANCA titer won't be very helpful, but if a positive MPO or a positive PR3 is more helpful. Another thing I'll say here is that patients can have ANCA negative disease, but they still have a positive PR3. And in that case, you're more concerned that the patient has a GPA. But if it's the opposite, where their ANCA is positive, but their PR3 is negative, the likelihood that they have true disease is lower. So I just mentioned the term likelihood. And so we actually have multi-cut point ROC curves for these PR3 and MPO ANCA ELISA tests. So this study comes out of Europe, where they look at the clinical condition of a patient based on which you come up with your pretest probability that the patient may have an ANCA vasculitis. And then depending on the ELISA number or how strongly positive your test is, you can determine your post-test probability. So if we think about our patient, he had sinus and pulmonary involvement. Surprising to me, the pretest probability for those involvements alone is quite low, only 10%. But when we think about his ELISA number, his PR3 number, which was in this category, very high, the post-test probability actually ends up being about 90%. And then we also, we have his saddle nodes deformity, we have his ANCA being positive, we have some biopsy results, which point away from other diagnoses, essentially confirming the diagnosis of GPA here. But just remembering that our ELISA tests are really great at helping us with pre and post-test probabilities. For those of you who may be asking, what does multi-cut point ROC mean? What am I talking about here with likelihood ratios? We did a talk on ROC curves, and so that's available on our YouTube channel for those of you who'd like a quick review. So feel free to use this QR code to take you there, and you can watch that video. Do any of you have any questions so far?
Sneha, can I make one comment and ask one question of Dr. Chan? So
Yes.
The comment is, there are very few things in the world that have a positive likelihood ratio that would take you from a 10% pretest probability to a 90% post-test probability. So that is a remarkably specific test. So it must have a likelihood ratio of 25 to 50 or something, which is amazing. So it sort of underscores your point. And then my question for Dr. Chan is, how likely is it that it's being missed on 2 tissue biopsies? So we have a bronchoscopic biopsy, and then there was that sinus biopsy that didn't show any granulomatous disease. Is that common and I'm just not familiar with it, or what's the chance of that happening? And Ed, I think you're muted, sorry.
Even though it used to be called, I guess it's still called granulomatous polyangiitis, I'm not sure granulomas is a major finding of it. I may be wrong, but vasculitis is, neutrophilic vasculitis is the classic histopathology associated with it. I don't think you see granulomas that you see with like TB or sarcoid or something like that. I have to look it up just to confirm. I think what you're really looking for is the vasculitis. And I guess, the transbronchial biopsy, which did not, which is commonly the case. I don't know.
Yeah, I actually didn't think he needed a bronchoscopy and a transbronchial once we had all the data. And with a big cavitary lesion like that, there's going to be a lot of necrosis. And I think it's even more likely to miss the primary pathology when you've got a huge lesion like that, as opposed to, say, a nodule that's not cavitating. So I don't put any weight in the negative biopsy.
Yeah, just, like a trivia, like pulmonary Langerhans cell histiocytosis used to be called eosinophilic granuloma, and you rarely see granuloma in that as well. So.
Thank you for that discussion. Yeah, I almost wish this patient had granulomas because the rest of his case is so classic, but who knows, maybe in 10, 20, 50 years, we'll change this name again because granulomas aren't very common.
Well, the patient had giant cells. That's close.
That's close. Okay, thanks, Dr. Albert. Good to know. All right, so I like to include healthcare disparities when we talk about disease processes. And so I wanted to just bring a little bit of that into today's discussion this is one of those diseases where there's actually an example of reverse disparity. And so what I mean by that is mortality rates are lower in the Black and Hispanic populations as compared to the white population. There needs to be more research done about the root causes of this, but just to remember that while a majority of our healthcare disparities today are related to racial and ethnic backgrounds, when adjusted for socioeconomic status, to continue to think about other structural reasons why these disparities occur, such as access to care, which is really important in a complicated disease process like this. Fortunately, the mortality rate overall for ANCA-associated vasculitides is declining, and so I think we're doing a better job of picking these up as well as treating them. And then so ensuring that when you do have a patient with these types of diseases, that they have good access to a subspecialist that they'll need to see. Rheumatology, certainly, nephrology if they have renal disease, but making sure that the PCP or rheumatology are following their renal function closely. Pulmonology if there is lung involvement, as was the case in this patient, and then ENT if need be, as in the case for this patient who needed surgery. And so I also like to offer some self-directed learning opportunities. So what I'll do is leave this image up here. Feel free to take a picture of it. And we saw some immunofluorescence earlier with respect to the ANCA antibodies and where they were directed in the neutrophil. Here is an image of a glomerulus. And the clue for this immunofluorescence is that this is a mesangial pattern, which can be found in the most common glomerulonephritis worldwide. So to think about what disease this is. And then additionally, thinking about what are our medium and large vessel vasculitides, something we didn't talk about today, but I think important to put in the context so that you're thinking about these illnesses as a continuum. Corey had a question in the chat. Corey, do you want to talk about what you were saying?
Yeah, I was just going to say, I know that when you treat ANCA vasculitis, there's like two different proven strategies. Like you can either do follow the ANCA levels until they actually clear, and then you can follow them, and when they get elevated again, you can start treatment again with rituximab, or you can just keep them on scheduled treatment. I think it's like every 6 months. And I just wanted to see, like, to the pulmonologist, what do they usually see? What do they usually, or what would you choose for probably the greatest success?
A little surprised that they started with rituximab, although it's a very effective therapy, at least until recently. It was something to be used with recurrence or with medication side effects. Although I can easily see where it would be a less toxic, effective regimen than Cytoxan or some of the other therapies.
My thought was that, like, unlike a lot of other autoantibodies like ANA, rheumatoid factor, which are not considered to be pathogenic, but just biomarkers, ANCA is considered to be pathogenic in this disease. And so I think that's the rationale for following it.
Perfect. Thank you so much.
Well, that's our case today. Thank you to the discussants for their excellent insight, Mike for presenting this case, and our expert discussants who gave me some teaching points that I hadn't come across even in making this case. So I appreciate that. Happy to take any other questions that folks have, but otherwise have a great rest of your day.
Yeah, that was great. Sneha, I'll give you a big thank you for putting this case together. That was awesome. And thank you to our residents.